Good morning. My study topic is clinical profile of endogenous endophthalmitis in a tertiary eye care center at Malappuram. So we know endogenous endophthalmitis is a severe form of ocular inflammation with the source of pathogens situated within the body, and it accounts for 2 to 8% of all endophthalmitis. There are many systemic risk factors for the same, diabetes being the most common. There are many studies on exogenous endophthalmitis but very few on endogenous. The aim of my study is to study the clinical profile, risk factors, microbiological profile, and treatment taken by patients who presented with endogenous endophthalmitis. This was a cross sectional study conducted in the Department of Ophthalmology in the last year. The age of patients, the demographic profile of patients, their underlying systemic infections, pre existing medical conditions, the source of infection if possible, the treatment taken, and the final outcomes were collected. Endogenous endophthalmitis was diagnosed clinically in the presence of significant vitreous inflammation with or without anterior segment inflammation. In cases where the fundus view was hazy due to corneal opacity or a cataract, a B scan was done to confirm the diagnosis, and MRI was done in stable patients to rule out intracranial extension. So all patients were given intravenous antibiotics, and the panophthalmitis patients who did not respond needed an evisceration, and endophthalmitis patients were given intravitreal antibiotics. Those who responded were repeated intravitreal. The intravitreal antibiotics were repeated. If no response, they were referred for a vitrectomy. These are my results. We had 8 patients, 5 females and 3 males in the age group, average age group of 61. The youngest was a 45-year-old male patient. And the most common comorbidity was uncontrolled diabetes. The source of infection varied, which I'll be coming to in the coming slides. The most common presentation was defective vision followed by pain. The left eye was predominantly involved. Half of the patients had, that is, 4 patients had no perception of light at presentation, and 5 patients had panophthalmitis. So we had 5 patients with panophthalmitis. This was the first patient who was a 61-year-old uncontrolled diabetic on dialysis who presented with fever and panophthalmitis and a no PL vision. Since she was not responding to intravenous antibiotics, she had to undergo an evisceration, after which her systemic condition drastically improved. The blood cultures, the evisceration specimen, as well as the dialysis catheter tip showed positivity for Pseudomonas aeruginosa. So that is most probably the source of infection. And this was another 69-year-old patient admitted in the ICU who developed panophthalmitis with a no PL vision, and she succumbed to her illness. The probable source was the lung because she was admitted for bronchopneumonia. She was again uncontrolled diabetic. The third patient had no comorbidity. She presented with panophthalmitis and a no perception of light vision. In order to prevent intracranial spread, an early evisceration was done. The blood cultures were positive for streptococcus, although no particular source could be identified. This was our 4th patient who was a diabetic on chemotherapy for AML, was diagnosed to have mucormycosis of the sinus with periorbital extension, and the involved eye went into auto evisceration within a week. This was another patient, diabetic, who was admitted for UTI, and the blood cultures were positive for streptococcus. The presenting vision was perception of light. We had advised an intravitreal injection, but the patient went elsewhere for a second opinion, later developed panophthalmitis, and the eye had to be eviscerated. This was another 65-year-old diabetic patient, again developed UTI after catheterization. He had a perception of light, but we gave him a dose of intravitreal antibiotics and referred him, but he did not go. The vision has dropped to PL negative, but he's asymptomatic otherwise now. The blood and AC cultures are negative. This was the 45-year-old male patient with no comorbidities who had a liver abscess and an endophthalmitis in the right eye. The presenting vision was hand movements plus. He went elsewhere for the liver abscess drainage. Prior to that, we had given him 1 dose of intravitreal antibiotics. But after the liver abscess was drained, his vision had dropped to PL negative, after which evisceration was done from there itself. The causative organism from the liver abscess specimen was entamoeba, but the evisceration specimen details were not available. This was an 56-year-old male, again with no comorbidities, who had a bee sting on the finger. He was very sure there was no sting near the eye, and the vision was PL plus, and he was given intravitreal antibiotics. But since there was no improvement, he was referred for a vitrectomy. He underwent early vitrectomy with lensectomy, which improved his vision to 612 with aphakic correction. So this is roughly what the patients had undergone. We had 5 patients with panophthalmitis, all of which had poor prognosis. And this coming to the discussion part, the mean age group in our study was 61, which was comparable with other studies. Laterality, we had more of a left eye involvement. The most common comorbidity was uncontrolled diabetes, which was seen in the studies by Pillai et al. And the most common foci in other studies by Pillai et al. Was UTI, which was also in our study. But in Western studies, it's usually IV drug abuse. The blood cultures, we had 37.5% positivity, higher in Western studies. And the aqueous and vitreous tap was, we got a dry tap in vitreous, and aqueous samples were negative, but higher rate of positivity was there in other studies. The most common organism was found to be equal for fungal and bacterial. We did not have enough numbers to come to a conclusion, but we had 1 fungal and 2 streptococci and 1 pseudomonas from blood cultures. And to conclude, diabetes was the most common risk factor, uncontrolled diabetes, and panophthalmitis at presentation had very poor prognosis. The culture positivity was also associated with poor prognosis. Any vision drop in a critically ill patient should be looked with caution. These are my references. Thank you.
Did all patients also get IV antibiotics?
Sir?
Did all patients
Yes,
also
sir.
get IV antibiotics?
All were given intravenous antibiotics.
So the ones who were in the ICU were based on a blood culture, or was it being given empirically?
That patient had bronchoalveolar lavage positivity.
And it was based on a
Acinetobacter.
culture, or it was
Culture,
just
culture.
it was based on culture?
Yes, sir. A vitrectomy we had referred, intravitreal antibiotics we had given, and no surgery. This is endogenous end of, so, all exogenous were excluded actually. Surgery within 1 year also were excluded. Any cataract surgery? Yeah, we had more of panophthalmitis, which was not, I mean, there are only very few studies, only 1 patient with panophthalmitis during the COVID time and all, but we had more number of panophthalmitis, but uncontrolled diabetes was the most common cause. Yeah. All were very uncontrolled, mainly on dialysis and all. And dialysis catheter tip is one source of infection which we usually miss in dialysis patients.